Ruxolitinib is a JAK inhibitor. It was recently approved as a therapy for patients that were intolerant or resistant to hydroxyurea. Hydroxyurea is the first-line therapy in most of the cases for patients with polycythemia vera. This is a therapy that is provided to patients that have a high risk of a blood clotting, and this is defined by being older than age of 60 or having a history of a blood clot in the past. These patients are usually treated with phlebotomy to lower the numbers, that's a bloodletting, with baby aspirin and hydroxyurea. Hydroxyurea is a chemotherapy by mouth. It eliminates the need for phlebotomy, and we target hematocrit, the blood cell count, below 45%. But about a quarter of the patients that are given hydroxyurea don't really do well. They may be resistant to it. They may have intolerable side effects, mouth sores, skin sores, low-grade fever, hair thinning, depression. They need something else. And here we have a new development, the JAK inhibitors. Ruxolitinib is now approved as a second-line therapy after hydroxyurea in patients with PV. These patients traditionally don't do well because there are no other options. We have a new option that actually targets the biological problem in this disease. The biological problem is hyperactive JAK-STAT pathway. It's an intracellular signaling cascade of proteins that leads cells to grow. In PV, this happens because of mutations in a JAK2 gene, JAK2 V617F and JAK2 exon 12. That's part of the diagnostic process. But with the ruxolitinib, a JAK inhibitor, we can inhibit the JAK-STAT pathway. We make cells grow less. We achieve the goal of control of blood cell count. We eliminate the symptoms. We shrink the spleen. We improve the outlook for these patients overall. Ruxolitinib is the first ever approved medication for polycythemia vera in the United States. It's approved as a second line for patients that are resistant or intolerant to hydrea. The initial study in polycythemia vera with ruxolitinib was done several years ago. It was a very small pilot study in about 34 patients only. We did not really know what to expect from that. I was involved as a principal investigator here in the United States on that study. We published this about 8 months ago, and to our surprise, all except one patient, which is 97% response rate, normalized the blood cell count within a month. Overall, when we look all the other benefits, and we look usually at 5 factors, we look not only at the improvements and the normalization of the red blood cell count. We also look at the white cells, platelets, spleen, and symptoms. About 60% of the patients, out of these 34 patients, normalized all the factors. The rest had partial response. And to my surprise, in fact, the FDA and regulatory bodies in Europe also recognized the important development here. Such a response has not been seen with any therapy, and in patients that really need help, that was major advance. Based on such a small study, the FDA allowed the performance of the randomized phase 3 study, which compared ruxolitinib to best available therapy, whatever the doctor wants to give to the patients, in a second-line setting for patients that are refractory or resistant to hydroxyurea.
In terms of the approval of ruxolitinib for the treatment of polycythemia, this was based on a phase 3 study called the RESPONSE trial. This was a randomized study of over 200 patients with polycythemia vera, specifically therapeutic phlebotomy-dependent PV patients with palpable splenomegaly and symptom burden that were randomized either to ruxolitinib up front at 10 milligrams twice daily or best available therapy. These patients were also often intolerant or resistant to hydroxyurea, and hydroxyurea was actually one of the more common agents used in the best available therapy arm. This trial, the primary endpoint of this trial was a co-primary endpoint of the proportion of patients that maintain a hematocrit less than 45% between weeks 8 and 32 of the trial, as well as the proportion of patients that obtain a 35% or greater reduction in spleen volume by MRI at week 32. So 21% of patients enrolled in this trial on the ruxolitinib arm met the primary co-endpoints, as opposed to 1% in the BAT arm. It also should be noted that patients enrolled on the BAT arm also had the opportunity to cross over to ruxolitinib after 32 weeks. Also importantly, secondary endpoint was symptom response, which I think is really the true benefit of this drug in a polycythemia vera patient. The symptom burden was greatly reduced in patients. In terms of the response trial, I think one of the important take-home messages of this trial, which was a trial designed to prove that ruxolitinib compared to best available therapy was more effective in inducing phlebotomy-free periods and reduction in splenomegaly, which is not unimportant, but I think perhaps the more important endpoint in this study, to me, was the secondary endpoint of symptom response, in which the overwhelming majority of patients treated on ruxolitinib had improvement, some degree of improvement in symptoms, and met the secondary endpoint of symptom response. And I think that becomes important as the drug becomes approved and a clinician is trying to figure out which patients in his or her PV population would be most suitable for ruxolitinib, which is an expensive therapy compared to, for example, hydroxyurea. So I don't think that the drug should be used indiscriminately for all patients in order to attain a therapeutic phlebotomy independent state, which was the primary co-endpoint of this trial. I think the patients that are most suitable for ruxolitinib at this time are really patients with significant symptom burden. And one of the things we learned from the landmark analysis is that patients with PV do have a significant symptom burden, whether it's the most common ones being fatigue, inactivity, pruritus, or most severe ones being fatigue and sexual desire or lack of sexual desire. So I think symptom burden is there. One needs to sort of identify it with their patient and make a decision whether the symptom burden was affecting quality of life and productivity, which was shown in the landmark analysis. So I think a treating physician really needs to be aware of the symptom burden of a PV patient and, for example, pruritus, which currently none of the therapies that we have are truly effective for pruritus. Ruxolitinib is a therapy that could alleviate significant pruritus in patients that have this particular symptom. Additionally, I think interestingly in the response trial there was a reduction in thrombotic events in the ruxolitinib arm when compared to the best available therapy arm. Now, this was not a primary endpoint, and this study was not powered to look at this difference in a statistical sense, but it sort of begs the question, which is, does ruxolitinib in this patient population reduce the risk of thrombosis, which essentially is why we often treat patients with polycythemia vera with cytoreductive therapies. So I think it will be important to tease this out in longer term studies, if this can be done in terms of risk reduction of thrombosis, risk reduction of progression to myelofibrosis or to acute leukemia. These are important endpoints as well that should be investigated or evaluated in the context of any JAK inhibitor.